No, this is not the one. There I am. Well, hello and good afternoon, everyone. It looks like we've got lots of people that are logging on. So let's give ourselves just a minute for everyone to get joined and then we'll jump right in. Thank you. Well, hey, good afternoon. This is Teacher Kirschbaum with the Healthcare Authority, Division of Behavioral Health and Recovery. Just checking to see if people can hear me okay.
Sure can.
Wonderful. Thank you. Thank you. Well, I'm going to go ahead and get started because we do have typically have a pretty packed agenda. Welcome all of you. Let's see, we have, if I can tell how many people we have joining us or with us on the call right now. I can't tell. Um, Either
We have
way,
about 86 right now, Tisha.
thank you. Thank you for taking the time to attend this Division of Behavioral Health and Recovery call for behavioral health service providers. I know I thoroughly enjoyed this time together, and I hope that all of you find it beneficial as well. My name is Tisha Kirschbaum. I am the Director of the Division of Behavioral Health and Recovery here at the Healthcare Authority. I actually think this is my first time kind of facilitating this call. So usually we've got Teresa Claycamp, who is managing this, but this time I'm doing it. So very much looking forward to this time together. Before we start, I just wanted to go through a couple of housekeeping items. Just so that we can all hear well, please mute yourself if you're not speaking. We do have the ability for people to ask questions, so you can put that in chat, and then we will make sure that we get to you. Also, just an FYI that this meeting is being recorded and will be posted on the Behavioral Health Provider Resource page. So because of that, just please refrain from giving out any confidential or patient information is very much appreciated. Thank you. So to kick things off, let's just preview the agenda real quick before we begin. So it looks like today we are going to be starting here with this welcome and kind of housekeeping. I'm going to be giving some updates, and then also we have an update from Sarah Mariani from our prevention section. We are then going to be handing it over to Jennifer Elzavuras. Excuse me, Jennifer, I did not pronounce your name correctly. She's going to be giving an overview of consent leak, which I hope that all of you find informational and helpful. Then at 2, we're going to be joined by Evan Klein, who also works at a healthcare authority, and he's our special assistant for legislative and policy affairs. And he's going to be giving an overview of some of the Medicaid updates that we have been experiencing lately, and also answer questions as you might have them. And then we'll be wrapping up our hour together. So for the agency updates, a couple of things I would want to bring to everyone's attention is it has been, I think, about 5 weeks now since Ryan Moran has joined us here at the Healthcare Authority. He is the new director at the Healthcare Authority, and we've been very excited to have him with. If anyone hasn't had the opportunity to get to meet Ryan or learn a little bit about him, I am going to put a link into the chat that provides some information about Ryan and his background. Ryan previously, before he joined us here in Washington State at the Healthcare Authority, he was in Maryland, serving as the Deputy Secretary for Healthcare Financing and as the Medicaid Director for the Maryland Department of Health. His background and career includes leadership roles in large integrated delivery health systems, including hospital, outpatient, and community health settings. And he really has focused his public service executive leadership in both state and national Medicaid policy capacities. So we are very excited to have Ryan here. And it's wonderful to have a permanent director again after kind of since Sue Birch left us in January. And then, of course, we had the wonderful Marianne Lindenblad, who was with our agency for about 8 to 9 months in the interim period. I also wanted to take a moment because right now we're in the part of the year where the Healthcare Authority and other executive cabinet level agencies have just submitted their decision packages to the governor's office for them to be considered to be part of the governor's budget. So I wanted to briefly give an overview from the Division of Behavioral Health and Recovery, what had been submitted this year. I'm also putting a link into the chat that you can click on that will give some additional information on the different decision packages that have been put forward. A couple of things to keep in mind with the decision packages for this year, because of the state's current budget situation, agencies were asked to be very thoughtful on what decision packages they would put forward, just because we are in a time of budget scarcity. To really be thoughtful about what is either legislatively already directed or it is absolutely needed, and try to minimize the requests for additional funding as much as possible. So one of the things that you might notice is that there seems to be just fewer decision packages put forward than has been in the past, and that is accurate. There are about a third of the amount that in other years have gone forward before. So some of the decision packages that we put forward to be considered was the ongoing implementation of certified community behavioral health clinics, also known as CCBHCs. Some additional funding to help stabilize facility-based crisis stabilization. Also, a request to support some of the agreements that we've made with the True Blood settlement, particularly with supporting a crisis stabilization facility in the Thurston Mason region. Also connected to True Blood was some ongoing staffing support for outpatient competency restoration programs, and then the ability to seek greater spending authority for our program gambling treatment program. And again, additional information on those can be found on the link that I put into the chat. Also wanted to give folks just a real quick update on some of the information that we are receiving from the federal government connected to the federal grants that DBHR receives, mostly from SAMHSA, the Substance Abuse and Mental Health Services Administration at the federal level. We have about 14 different grants that we receive from the federal government. Some of our biggest ones you're probably aware of. They are our mental health block grant and also our SUPTERS block grant, previously known as SABG. Every 2 years, we have to apply for those two grants, and we just submitted our application back in September. We have not heard back yet on where we're at with that application, but as soon as we do, we sure will be letting people know. If any of you were part of just our application process or the work that we do to kind of stakeholder and get feedback for our block grant application, very much appreciate the support that you all provided. We also have our state opioid response grant that we recently just got our ongoing notice of award for. And then also we have a flurry of other discretionary grants that we receive from SAMHSA and also the Department of Justice. Something that's been a little bit different that we have noticed is there has been a different level of scrutiny and some questions about the block grant that we're seeing under this administration that we haven't seen in the past. And so we're just working through kind of how to best answer those questions and ensure that we continue to receive the funding that we need for people to receive the services here in Washington. I think I might have seen a hand go up for a second.
It was an accident. Sorry, Tisha.
Sorry. You bet. And now I'm actually happy to turn the mic over to Sarah Mariani from our substance use prevention and mental health promotion section here at DBHR. And I think she had a couple of things she wanted to get on people's radar.
Thanks, Tisha. Appreciate those updates, and welcome everyone. Good afternoon. I hope you're coming into fall nicely. Yes, a couple quick updates for you all from our section's work. We wanted to let those of you that have participated in the Prevention Summit, the annual Prevention Summit we've had for over 30 years, is typically in the fall. And we have use this as an opportunity to have training and networking for youth, for volunteers, and for professionals that are engaged in prevention and promotion work, and supported interdisciplinary training across the continuum. So in looking at where we're at now, we wanted to let folks know that we have had to postpone this year's Fall Prevention Summit. We are looking at opportunities to host it in the spring and how we can build that in and also retain some of the goals that are part of typically the Spring Youth Forum, which is the large youth gathering that we have to highlight and support youth work. So we're looking at how, given the resources, how we can try and do that in the spring. More to come on that. We appreciate your support in that. We know it's an important conference and opportunity to come together, especially given the times. And we need to be able to do this within the resources we have. So thank you for your patience with us on that one. The other update that we wanted to provide it from some of our work that we're really excited to announce. It was a long way getting here. Every 2 years, we do the Healthy Youth Survey, which for those of you that maybe are less familiar, the Healthy Youth Survey is a student survey that we do in grades 6 through 12 every other year. This is an opportunity really for the state and for locals to understand the youth voice, and for us to understand what is the temperature, what's happening with youth. This helps inform our state plan, it helps inform local plans, school district plans, really, really valuable data and a really vital tool for adding youth voice into our planning and how we resource services out into communities. So the exciting announcement is it's coming up this fall and registration is open. And so for those of you, I'll drop some links in the chat here just momentarily. Can try to stay focused. But I'll drop some links in. There is an opportunity for you to look and see if the school districts in your area have registered or not. And if this is something that you also find valuable for your work and in your community, we would encourage you to support your local school districts to sign up and register for the Healthy Youth Survey so that we can get that data out. We also have, if you haven't seen it yet or you haven't looked recently, we have an updated Healthy Youth Survey website that has a dashboard. You can get a lot of this data really easily at your fingertips, especially helpful for those of you that do grant writing and you want to be able to put some data in. So I'll drop both those links in as soon as I stop talking. And then the last piece that I wanted to let you know about is actually something that I'm kind of advertising for some of our partners, but it relates to our work and we're excited that it's available. Department of Health in partnership with Liquor and Cannabis Board, as well as partnerships with other state agencies, including us, has released the Bud Tender Training Series, which is specifically for cannabis retail staff and helping how we have conversations with legal adult users of cannabis and how to keep themselves safe when using and understand and know the health impacts and be making good choices for themselves based on their use. So it's about a 45-minute training and you can find that information on the Department of Health website. Those are the announcements I have. I'll drop the chats in or take any questions if there's time, which I'm guessing there may not be. I'll kick it to you, Tisha. Thanks.
Thank you, Sarah. Very much appreciated. Sounds like perhaps Liz Venuto also had an update that she wanted to provide.
Yes, we have two from our prenatal through 25 behavioral health section, and I will keep them brief. One is that we have two new facilities. They are post-inpatient transitional housing facilities that are operating, one on the east side of the Cascade Mountains and one on the west side. They are specifically designed for young people 18 through 24 who are stepping down from inpatient care. They are accepting referrals now. One is located at Excelsior Wellness on the east side of the state and on the west side at Friends of Youth. So just wanted to let folks know that they were out there. And dropping in chat, the Washington Thriving Prenatal through 25 strategic plan has been underway for some time now. Hopefully that's not new information. Just if you wanted to be connected to that work to see how it's developing, see how some of the strategies are coming out, Just wanted to provide the link one more time, and a report should be coming out after November 1. So we should be back on this call in several months introducing the report. And that's what we've got from our prenatal through 25 section.
Thank you, Liz. Very much appreciate it. Hey, Laura, you'd put a chat in that it was a little hard to hear. Liz gave two updates. One was just stating that a new type of facility specifically intended for kids who are exiting from an inpatient setting that needs some help with housing has recently opened, and also a plug for people to check out Washington Thriving. So Liz, maybe you could put a little bit of the information in chat in case anyone couldn't hear it. And well, here we go. And someone else just asked for a link for the resources we talked about for the young adults stepping down from inpatient. Thank you. All right, do we have Jennifer here to give the update on consent link?
Yes, hi, Chisha.
Hello. Do you have some slides you were going to share? Or would you like Sandra to do that for you?
I got it. You should be able to see my screen now.
Sure can, thank you.
Great. Well, hi, everyone. Good afternoon. Thanks for inviting me to present today. I'm going to talk about the electronic consent management solution, which is the Healthcare Authority's consent link system, as we call it. My name is Jennifer Visudas, as you heard. I'm the Health Information Technology Program Manager here at Healthcare Authority. I'm really excited to share this with you. Let me start off by talking about where this all fits within the Healthcare Authority. Consent Link is one piece of HCA's goals to modernize our health technology infrastructure, connecting over 2.9 million people in the state to over 75 health and human services, with the goal to make it easier and more equitable to access our services using technology that will create a better user experience and reduce the barriers people have to access these services. So Consent Link is just one component of all of these different programs that make this up. Some of the other major initiatives that you might have heard of are, like, for example, the 988 Suicide and Crisis Lifeline, the Healthcare Management and Coordination System, and the Community Information Exchange, just to name a few. Some of these programs are at different levels of rolling out. So Consent Link is just one of these multiple programs that are coming out. So some of you might have heard of Consent Link in the past or been part of our webinar. I'm going to take a step back and just talk about what it is that we're trying to solve. This solution was really built from conversations with providers to find a better way to share data, especially those providers that see patients with high medical needs. And specifically, we're trying to solve the issue of consent forms and sharing those consent forms. From feedback that we've gathered from providers, we've learned that when a consent to share information is, or release of information, or it could be a TPO form, a treatment payment operation form, when there is a need to share that and the data, there are high administrative burdens to get that form delivered and signed and delivered and sent to the appropriate recipients. And that could be from the sending provider to the receiving provider. We've learned that there are multiple barriers and inconsistent processes full of bottlenecks when trying to get these forms signed that could lead to delays and overall just have a frustrating experience for the patient. And so with this system, a consent form would be digitized and housed in the solution, and it could be accessed by the provider who is sending it and who is receiving it. And so currently this shared document system, again, houses that release of information form, ROI forms, TPO forms, treatment payment operation forms. This is a pretty new system. We launched in August of 2024, and it is a free system to use by Washington providers. The system, again, facilitates that patient authorized exchange of their data by the consent form. The system eliminates disjointed processes since all of these forms would be online and allows for quicker access for the consent. So we would remove that faxing aspect of the sharing consent forms. And, you know, it is trying to simplify workflows and increase provider confidence that we know that the forms that are configured in Consent Link are compliant with policies and rules that are required, such as HIPAA and or 42 CFR Part 2. And so to access consent link, you would use a web portal to log in. And I'll talk a little bit about that in the next few slides. Let me talk about the onboarding process first. Onboarding takes about 6 weeks. It is a process where our team and the organization configuring their forms would first we take a look at the forms, we make sure that the forms are compliant. The organization must be in Washington State. They have to serve Medicaid population as part of the patient population that they see. The forms need to be compliant with HIPAA and 42 CFR Part 2, and we are happy to take a look at those and help out in identifying those elements, and really be ready to move beyond manual or paper-based consent workflows. There is training available as well, and we make sure that all of the people who will be using this from the organization standpoint are trained and have an opportunity to test their forms in a testing environment. Okay. So let me talk about what the system offers. Like I said, we launched ConsentLink about a year ago, and we started with very specific features. With the goal here is to add additional features as we move into the future. The current features that we have are outlined here. What we found from conversations with providers and from working with a variety of different providers is that each provider, each organization has a form that is slightly different, even though all of the required elements are on that form, they align differently. And so our system has the feature of optical character recognition scanning, which would allow a form to be scanned in or uploaded as a PDF. And the system is taking this optical character recognition, or OCR, and is digitizing the consent. All of that metadata is taken from that form, and it is populated into the patient's profile. And so it's not just an image that you see, but it's in fact, the data is actually used in the system. Another of the features is this consent expiring report. It's one of several analytic reports that we offer. Many providers express that it would be good to see which consents are expiring within a given time frame. And so this report allows you to get ahead of your workflow, for example. And we also have a suite of other types of customizable reports that can apply analytics to your organization. For example, who's accessing the form, or audit type of reports as well. Another exciting feature that we have is this cross-organizational access. This is the system built-in logic so that only the sending and the receiving providers can see the forms. This is, at the end of the day, a consent form that is shared between two parties, and only those two parties could see the form that the patient has authorized. And last, a bullet here is the customizable role-based access. That means that within an organization, there are specific staff that will have more access than others, depending on what the role is within an organization. So we have the ability to customize who is seeing what at a staff level. I will move on to this next slide. Currently, this tool will help organizations who are still using the paper and fax to send their ROI forms, their release of information forms. That is who this will currently most help, I would say, because of the features that we have and some of our limitations until we add those other features. And this diagram shows that current state of ConsentLink. And you'll see two main pathways here. You'll see a client or patient visiting a provider's office, and you see two pathways. This top pathway is the pathway that we currently offer. And that is that a provider would access ConsentLink via our web portal. They would use Secure Access Washington, or SAW, to access this portal, and there they could create, modify, revoke a consent in ConsentLink. And this bottom pathway, the second pathway that you see here, is one that we recognize is important and that is our next priority as we add more features to ConsentLink. And that is the pathway where, excuse me, where a provider is accessing ConsentLink via their EHR. And that could be either a tab within their EHR, it could be another widget within their EHR, it could be a link that takes them to ConsentLink, but it all happens within their EHR, which is the interoperability or the connections of EHR and ECM or ConsentLink. That is a feature that we understand is very important. We've heard the feedback, and that is our what we're working on next with the system. This next slide, excuse me, also talks about future functionalities. As you can see here, there are a ton of different pathways that we want to connect to in the future, and these are all really dependent on the other programs. I briefly mentioned at the very beginning that we want to connect to other systems like 988. For example, if there's a consent on file, when a patient is seeking critical mental health help, that patient might be able to see the provider, excuse me, might be able to connect that data faster to the provider. That's just one example of how this can connect. We also see other features, for example, like the ECM mobile app, and that could be a way to have clients sign their own consent remotely or revoke their own consents remotely. This could be an app, it could be a link that is sent to them, for example. So it really, all of these things are planned for the future, but depending on other programs and again, just all of the other situations that are happening across the state, it might be a longer timeline. But that is our goals. These are our goals, and I just wanted to share what this looks like. Okay. So this is a screenshot of ConsentLink's testing environment. This is not real data, but I wanted to provide a visual of what the dashboard looks like. This is what a clinician would see when they log into ConsentLink. Here you could see a client or patient panel. You can see the consents that are on file and see which forms are scanned in. Depending on the configuration of the individual's account, they can either see additional reports or additional settings. ConsentLink, all of the consents would be under the person's name, so you'd be able to access them or revoke them here within this this system. And we're very happy to, if you want to learn more or see the entire demo of the system, feel free to reach out to us. We're happy to do one-on-one calls and kind of go through the entire system. This is just a quick screenshot of what it looks like. And I know because I only have a few minutes left, I just want to say that our contact information is econsent@hca.wa.gov. I will post it as well as our website in the chat. But I want us to reiterate that ConsentLink offers an intuitive interface for creating, scanning, and managing our consents. It includes reporting tools and alerts for upcoming expirations. It supports HIPAA and 42 CFR Part 2 regulations that are built into the system. And again, we're happy to meet with you if you want to learn more. If you want to sign up to our GovDelivery, you can use our website, which I will be posting in the chat now. And I think that is my time. Tisha, I'm not sure if there's questions, but I'm happy to take them offline if needed.
Thank you, Jennifer. Very much appreciate this. The one question that you had, which got a couple of thumbs up, is just people want to know if there's a link to learn more about this. And it sounds like you were planning on putting that into the chat, right? You already did. So I think we are good. But thank you, Jennifer, for coming and sharing.
Thanks so much. Have a great day.
Okay, so now I think what's next on the agenda is hearing from Evan, and he's going to give us an update on some of the changes that we are experiencing in the Medicaid space. Evan, would you like us to share some slides?
I am happy to share my screen if it's easy enough.
Go
I
for
have
it.
some
Yep.
slides open.
Thank
All
you.
right. And just checking that folks can see my screen. Great. Thanks. So I'm Evan Klein. I'm the Special Assistant for Legislative and Policy Affairs here at the Healthcare Authority. I handle both state and federal relations for the agency. Have been working very closely with our Medicaid teams, our behavioral health teams, and many of our agency leadership over the past several months to really unpack and start to digest the impacts of a variety of federal changes that are impacting our state's Medicaid program and really states around the country. So I'm going to share just a brief overview here today. I want to go quick so that I can reserve some time for questions. I have a lot of content in this deck that talks to both some of the provisions in the federal budget, but also some federal rules, recent federal guidance, also some of the activity that's happening related to data sharing at the federal level. So I can jump around if there are any questions or if that would be helpful, and probably won't cover everything in this presentation. As I get started, I do want to acknowledge that what I'll talk about in relation to the Medicaid program is not happening in a vacuum. There is a lot going on in the healthcare delivery space, also with other social services. The federal budget has implications for the individual market, for our SNAP programs, for TANF programs, and can be pretty far-reaching. So giving you a little bit of detail around what's happening in Medicaid, but there's a lot else happening with coverage that may impact similar populations and you as providers particularly. Starting off, just want to highlight when we are getting into kind of implications of federal budget provisions and what HR 1 is how I'll refer to it throughout the presentation. There's a lot that the agency and really the state was already grappling with prior to this summer, and largely driven by a number of federal rule changes, from prior authorization rules to managed care access rules to some eligibility and enrollment changes that are being required by the federal government, all of which provide backdrop to the work that we're doing as an agency and impacts that are going to be felt by the delivery system over the next couple of years. I'm not going to spend a ton of time here. I think the highlight, though, is in April of 2023, we were entered into a mitigation plan with CMS around noncompliance with classic Medicaid ex parte renewals. These are renewals for individuals who are enrolled through DSHS, the classic Medicaid population, age blind disabled. With a compliance date of June 2027, it's requiring us to make some major changes to state eligibility systems that have to occur in the next couple of years and really overlap with some of the major provisions I'll talk about in the federal budget, HR 1. Also, just wanted to highlight here, because this has some very particular impacts for providers, there were some recent changes to federal guidance related to what constitutes a federal public benefit under PROWARA, prohibiting lawfully present non-citizens from accessing benefits. It has the potential to significantly limit access with providers that receive federal grant funding. We're awaiting additional guidance to inform the scope of impacts. The good news here is this is currently enjoined by federal courts, and we'll talk about that with a number of these provisions. There's a lot of activity that's happening through litigation that is inhibiting enforcement of some of these major provisions that we'll reference. So transitioning to the federal budget, as I mentioned, kind of HR 1, this is a budget bill that was passed by Congress in July earlier this summer. It contains a number of provisions that impact Medicaid, but as I noted, also food assistance and the state's individual market coverage. We anticipate that it's going to lead to potentially hundreds of thousands of individuals losing health insurance coverage, be it from Medicaid or the individual market, but it's going to impact hundreds of thousands more. Some of these provisions are very sweeping, and at the very least will create burden and risk of loss of coverage to a number of Washingtonians who are enrolled in our state's Medicaid program. And as we'll reference, we are still assessing the scope. There's a lot that we don't know today. We're awaiting detailed federal guidance to ride along with the budget provisions. We're still working on kind of the business requirements as an agency for implementation and what this will really mean over the next couple of years. So I won't spend a ton of time here. This is just a snapshot of the major provisions that we're tracking in the federal budget and when they take effect. So kind of showing the cascading effect over on the right, and really highlighting that some of the major impacts of the federal budget won't be felt right away, which in a sense is a good thing, right? We aren't going to see significant losses of coverage immediately, and we still have to prepare for those because they are coming, and the changes to eligibility, the major system changes that come with that, and the loss of federal funding that starts as we get into 2027, 2028, and beyond. Still scoping the specific impacts. I know you've probably seen, if you've been tracking this in the news or through other press sources, a lot of estimates of what the loss of coverage will look like as a result of the federal budget. We're still undertaking some internal analysis to the state as to what that might look like, provide some projections to inform the upcoming state legislative session in particular. But what we do know is that over 620,000 Washingtonians are going to be impacted by the new work requirements and changes around redetermination timelines in the federal budget. Around 30,000 lawfully present non-citizens are going to see direct restrictions to access because they're going to lose coverage because of eligibility changes. And there's going to be billions of dollars of federal funding that is reduced as a result of the policy changes in the federal budget. The most immediate provision that impacted our state was a prohibition on federal funding going to Planned Parenthood. It provides some description in the budget, but it's really a focused provision targeting Planned Parenthood providers. For Washington, that's around $11 million per year in federal funding that we've been drawing down to cover reimbursement for services. Enforcement of this provision, this slide, I should actually say, is dated at this point. So the bullet at the bottom is inaccurate. I need to update that. But enforcement of this provision was enjoined by federal district court, but it was overturned late last week by the First Circuit. So that provision is actually in effect. There's 2 lawsuits that are pending in federal court that I won't get into here. The good news, though, is the state has set up its systems, and we have gotten agreements from the governor's office and the state legislature to backfill these loss of federal funds with state dollars, which means that Apple Health clients can still get access to services through Planned Parenthood today. And there's really no change on the provider side. They shouldn't see an effect. It's really an accounting mechanism for us. So that is the good news, but certainly tracking what's happening in the courts and the loss of funding there. As I mentioned, there are some relatively immediate changes to eligibility. This is probably the biggest change we'll see within the next year to eligibility requirements. And it's a prohibition on certain lawfully present non-citizens from accessing coverage. It begins October 1st of 2026. So these are individuals who are refugees seeking asylee status, or other non-citizen adults in Washington. That's roughly 30,000 individuals. They may be eligible for other programs, including coverage on the exchange or emergency medical coverage. But access to comprehensive benefits will be limited, and there may be some financial burden that gets created as a result of them losing access to comprehensive Apple Health coverage. There are also major provisions that will take effect really January 1st of 2027 related to work requirements. Then I'll talk about redeterminations as well that have a concurrent timeline. Work requirements, I would suspect many of you have been tracking this. This has gotten a lot of press and will have significant impacts to Washington State and really every state's Medicaid program across the country. It's conditioning eligibility for individuals who are aged 19 to 65 on working or meeting other community engagement requirements for at least 80 hours per month. It applies to the kind of adult expansion population in Washington. As I noted previously, that's around 620,000 individuals. There are varying estimates of what the enrollment losses might look like as a result of these provisions. I think where we sit, all of the work we're going to be doing is going to be obviously to try and manage compliance, but also to mitigate the impact on clients. How can we create automation with our systems, reduce the burden on individuals as they're applying for coverage or renewing coverage, and try to keep as many people enrolled as possible. There is a provision in the federal budget that allows states to apply for a waiver to delay implementation by December 31st of 2028, a 2-year delay, and a requirement to receive that waiver, a state must show a good faith effort to come into compliance with the provisions in the budget. But we should highlight that the waivers are all kind of fully discretionary with CMS. So where we sit today, we can't provide any certainty to the state that we would be able to get a waiver or that we'd be able to delay compliance beyond the beginning of 2027. So we're really working fast to scope what the impacts would be and how, again, we can mitigate those. There are a number of exemptions to the work requirements in the federal budget. The work requirements won't apply to these kind of different classes of individuals. As I noted, we don't have details yet from CMS, so we don't actually know what the documentation requirements might look like, for example, or what some of these provisions might mean. You know, medically frail, could mean quite a few things. We're waiting for additional interpretation from CMS. But some of these provisions have, specific impact in the behavioral health space. So just calling out alcohol use and substance use disorder treatment, individuals who are incarcerated or recently released within the past 90 days would both those kind of categories of individuals would be exempt from having to meet the work requirement provisions. And again, this is focused on individuals over aged 19. There are also changes related to the frequency of eligibility redeterminations, which is another burden on individuals for accessing coverage. Today, we redetermine individuals' eligibility every 12 months. The federal budget requires that to be every 6 months beginning December 31st of 2026. It still impacts that adult expansion population. Roughly 80 to 85% of the population automatically renews, and that's because there hasn't been a change in income or what they've reported matches what we see in our state systems, and we can automatically renew them. But there's around 15% of the population annually who need really active management, and we anticipate that this more frequent cadence of redeterminations is going to drive a lot of administrative burden for the agency and our sister agency, DSHS. But also have a significant impact on that portion of the population. Those are individuals who might have really changing circumstances in their life, and having to come back in and update that information during that time with the state, creates a kind of barrier to accessing care, and we would expect to see individuals losing coverage as a result, probably for procedural reasons. Won't spend a lot of time here because this provision doesn't take effect until October 1st of 2028, but there is a requirement to institute cost sharing in the Medicaid program today. There's no premium or cost sharing obligations for our Apple Health clients. There are some major impacts around state-directed payments that start to take effect in 2028 that I will talk about. I do want to just emphasize that the provider tax and state-directed payment provisions in the federal budget likely won't be felt directly by the behavioral health side of the delivery system to the same extent as our state's hospitals. That's because the state-directed payment prohibitions or kind of curtailment in the federal budget don't impact some of the professional services directed payments that the state has recently utilized. Some of you may be familiar with some of the recent increases in Medicaid reimbursement for behavioral health services that have been funded in our state budget. Those are not implicated by the federal budget provision. But it does have a significant impact on Washington, particularly for some directed payment programs that we leverage for hospital services. So we have a hospital safety net assessment. We also have an inpatient and outpatient directed payment program for the University of Washington, both of which have been increased by the state legislature in recent years and pay much closer to average commercial reimbursement rates kind of in the aggregate for our hospital services in the Medicaid program. The federal budget requires that those start to ramp down by 10% beginning in 2028 until not exceeding Medicare payment levels. For Washington, we anticipate that's going to have a roughly $1.5 billion impact annually once fully felt across our hospital delivery system. So that's a reduction of reimbursement going into the delivery system. So again, that ramp down starts in 2028, won't be fully felt right away as it'll take a couple of years to get down to those Medicare levels, but pretty significant impact. One of the few provisions I would say in the federal budget that does provide some positive news for us here in Washington is the opportunity, at least, to apply for funding to support the state's rural health delivery system. There's a $50 billion program in the federal budget. It's $10 billion annually spread across 5 years that allows states to apply for funding. It's a one-time application for participation for that full 5-year period that would allow states to utilize federal funding to kind of invest in rural healthcare, promoting care, supporting providers, investing in technology, otherwise assisting communities. The application deadline is November 5th. We are working in earnest in support of the state's application. HCA is leading that work, but working in close collaboration with the Department of Health, the Department of Social and Health Services, and the governor's office. We've been doing a lot of stakeholder engagement and outreach. And to be frank, we are still actually soliciting written comment. I know there are a number of behavioral health providers and organizations that have provided feedback to the agency already, but we are receiving written comment through the end of this week, at which point our written comment period will be closed, but we would still love to hear from you if there is any insight that you're able to provide the state as we're working through that application. No guarantee that states will receive funding, but we remain optimistic that states that apply and meet the base requirements of the scoring metric outlined by CMS will receive funds. They'll apportion about half of the money equally across states that are approved, and then the other half is discretionary. So if we have our application approved, we would be able to receive $100 million per year, so a minimum of $500 million across the 5-year period. But that could exceed 500 million depending on some of the discretionary aspects of the application. More details on that sit behind this slide, so happy to answer questions there. We'll also just note we have a website. I can drop the link in the chat or we can share it around. And there's a public webinar on Thursday morning at 9 a.m. that the agency is hosting for those who might want more information. Those aren't the only provisions that impact the Medicaid program. There are others that I won't spend a ton of time on. I'll just, of this slide, highlight that it does shorten, the federal budget shortens the period of retroactive coverage eligibility for expansion adults. That's from 3 months to 1 month. For all other Medicaid applicants, that's from 3 months to 2 months. This will have an impact on provider payment. I think it's just something for us to understand is that it's going to change our ability to reimburse for services that may have been rendered before somebody comes in the door and gets enrolled in the Medicaid program, because we cannot retroactively apply coverage as long as we have been used to. So I just wanted to call that out from this slide. From there, I have some material on data privacy. I'm going to maybe not go into that in any detail so that I can save time for questions from this group. And happy to go back through any of the other material. Tisha, happy to turn it over to you if there's anything you think I missed or kind of color commentary you wanted to provide. But we'll say thank you for the opportunity to present today. I know that this is really important work and it's on top of everybody's minds right now.
Thank you, Evan. A couple of things in the chat. Multiple people have been asking if they can get a link to the slides or access to the slides. I'm not sure if you can put that in the chat or not. And then also there was a question about work requirements, and specifically about some of the question was the only mental health conditions that qualify for a waiver, which I think we're talking about the work requirement waiver, are AUD and SUD.
Yes. So let's see, I'm going to check back on. I provided a link in the chat to a PowerPoint that we have maintained that's up on our website. It's a little different than these materials, but largely the same content. So I think it's a great reference point if you're looking for any of the information that I just walked through. When it comes to work requirements and the exemptions, I believe that the two that would be most relevant to this group and kind of the true kind of behavioral health work would be the AUD, SUD exemption, and then the exemption around incarceration. We don't have any details that really sit behind that. So this is really where it gets complicated for us as we are, I think, our agency director, Ryan Moran, put it early in a similar presentation earlier today. We're trying to build the plane as we fly it. We know that the compliance deadlines require us to get into developing system changes and staffing up for this work right now. And we don't know exactly how CMS is going to interpret some of these provisions. We're working off of a budget document that is very high level and doesn't provide the level of detail like what type of conditions may qualify for some of these broad exemption categories. So it's a great question, and we're tracking, but unfortunately don't have that degree of detail.
We're just not sure yet. Other questions? I do believe, let's see, there was, this is a slightly different topic, but something that was put in the chat is just the Support Act was passed today or recently passed.
I will have to read up on that. I
know.
I've been in meetings all day. That's good to know. Thank you.
So one of the things I do want to keep on people's radar, and Evan mentioned it as well, these are pretty significant changes, and we don't have all of the information yet. And we're attempting to get the information as we understand it out as best as we can. There are links on the HCA website that provide both a similar PowerPoint and also a one-pager on some of these changes if people would find those helpful. And as we learn information, we're trying really hard to kind of keep those sites updated to be able just to make sure that people have a place where they can go to gather information as best they can.
Hey, Evan.
Yeah.
Is it possible that the current sort of negotiations in Congress around shutting down the government or not, like what, could changes to what is it called? H1 or whatever it is, the bill.
HR1.
HR1 could be included in that if like in a negotiation about not shutting down the government. Is that possible? I don't know. I'm reaching for straws here.
I appreciate your optimism. What we know is that congressional Democrats are trying to leverage their ability to filibuster in the Senate to get some concessions in the healthcare space. And some of that has included Medicaid provisions, trying to get Congress to walk back some of the provisions that were in HR1. I don't know how realistic those negotiations are. I think there has been a lot more pressure, and to some extent a little bit more bipartisan pressure around some of the changes or the need for funding in the individual market space. So they're called enhanced advanced premium tax credits, but some enhanced federal subsidies that have been in place throughout the COVID era and have been helping subsidize access to individual market coverage. Pretty significant subsidies that are keeping people enrolled in the exchange. Those are set to terminate at the end of the calendar year. And there has been quite a bit of congressional debate about trying to reauthorize those as part of these budget negotiations that are taking place this fall. So if we're to see any movement in that space, I'll happily remain optimistic with you that Congress may take up some broader provisions that trickle into Medicaid and perhaps roll back or mitigate some of the effects that we just talked about. But I think there might be more emphasis right now on those individual market provisions if we were to see any movement in the next month.
Any last questions for Evan before we wrap things up? All right. Well, thank you, Evan, for joining us and providing the information. It is very much appreciated. Also, a huge thank you to Jennifer for sharing information on Consent Link, which is a tool for electronic consent management. Also to the DBHR staff who came and provided updates. And of course, our biggest round of thanks are to all of you for the work that you do every day. Thank you. Please keep doing it. And also for joining us this afternoon and sharing your time with us all. Thanks to all and take care. And we'll see you back here in November. Take care, everybody. Bye-bye.